This conference will now be recorded.
All right, folks, very good. So we're looking at the chapter in the cardiovascular system, looking at the blood. So the first, this week here, we're going to be looking at the blood, then we'll be looking at the heart and vascularity and such, and talking about blood pressure and other issues. So today, again, like I said, we're going to be looking at the blood. I also have for you all a Word document that I'll be posting later on, but I'll just show it to you right now. So this has the erythrocyte disorders. Okay, so you'll see there as far as red blood cells, white blood cells, platelets. And so that's a couple of pages there, 3 pages Word document. So that'll also be an addendum to the PowerPoint that we're going over today regarding blood. All right, so I'll share that with you all at the end of the class. So let's look at, we'll start with the slideshow here. So as far as the understanding of that, blood is a fluid connective tissue, right? We recall that we've learned all the way from the beginning of class, as far as in this Cengage 5th chapter, but 4th or 5th chapter, depending upon which text you were studying under for A&P1. So we have here knowing that blood is a fluid connective tissue, and it's different in that the matrix upon which the cells are within is a fluid matrix, right? It's a fluid matrix of plasma. This is the fluid portion, approximately 55%. The formed elements, when we think formed elements, you need to think in your mind cellular components of the blood. So we have the red blood cells, the white blood cells, the platelets, or AKA, properly known as the erythrocytes, the leukocytes, and the thrombocytes. Here we're seeing as far as a result of spinning and being able to look at the separation of the plasma from the formed elements, we have here that you'll see that the plasma is 55%. And you'll see here that the formed elements we have contained are the red blood cells, the platelets, and we have the different white blood cells, the neutrophils, basophils, eosinophils, lymphocytes, and monocytes. Okay? And know that the monocytes, they are going to become something over a period of time. They're going to become macrophages that are really the cleanup crew for the human body. Functions of the blood. We kind of have an understanding of this as far as knowing that, in particular, just even as a layperson understands that oxygen and CO2 are transported via the blood, whether it's oxygen from the lungs, from the pulmonary circulation into systemic circulation to the tissues. We have oxygenated blood go into those tissues, and then we have the deoxygenated blood coming from systemic circulation into pulmonary circulation in order to get removed from the body and upon exhalation. Okay? Nutrients, waste, hormones also traveling present within the blood. Very important to move them from one location to another. Regulation of our body's pH, and also helping with regulating temperature. And knowing that, so when you have a ruddy appearance, a flush appearance, realize that the blood vessels are dilated. So there's vasodilation going on. So there's release of heat. So there's more blood flow closer to the surface of the skin, which will in turn remove and release heat. Right? We know this. We can touch someone who looks all red in their appearance. We can put the back of our hand up against their forehead and feel, or against the area that's been affected, that's inflamed, and you can feel the heat coming off of the body, off the skin. Involved in also clotting as far as a protective mechanism. So you see here protection against, like, is the immune response, but also how about healing opportunities? So healing processes as far as clotting, the healing of damaged blood vessels, and the stoppage of bleeding, hemostasis. Again, protection, dealing with the immune response, working with, in very close conjunction with, the lymphatic system. Maintenance of body temperature. So in order to, again, if body is very hot, we'll have a vasodilation occur upon the epidermis and below the epidermis, in the dermis layer, right? Because again, remember that the epidermis is epithelial tissue, which is avascular. So in the dermal layer, we have these blood vessels will dilate and allow for heat to remove from the body. And then as far as osmotic changes will take place and the maintenance of fluid levels in the body. At that for now. So the erythrocytes are the red blood cells. They account for approximately 95% of the volume of the blood cells. Quite interesting, right? Even you could even say that they account for even more than that, between 95 and greater percentage. Really, when you look at a blood smear, as we did in ANP1, you would see that predominantly you saw red blood cells, erythrocytes, and only a few leukocytes interspersed throughout the slide, the sample. Now, this is the leukocytes, the white blood cells, small percentage, folks. There are granular and agranular leukocytes, and know that the granular ones are, this is terms that were used early on in microscopy. And so really when you look at them both, they both have a slight granular appearance, but it's really the agranular leukocytes are much less granular in appearance than the granular ones, which is the NEB, neutrophils, eosinophils, basophils. The monocytes and lymphocytes, these are the agranular ones that are considered the white blood cells. I put a mnemonic here regarding never let monkeys eat bananas. This is the as far as the occurrence within the blood. So primarily, as far as the white blood cells are concerned, we have neutrophils, right? These are the neutrophils are the ones that are involved in really attack on bacteria and such, and so they are the predominant in numbers. Then we have lymphocytes second, monocytes third, eosinophils, and then lastly basophils. Okay, so when you're looking at a slide, a blood smear, you're not going to see a whole lot of basophils. Primarily, you're going to see neutrophils present. Okay. And the platelets are involved in your clotting formation and such, so clot formation. So we'll look at this a little bit more detail. So here you're seeing at the very top of this image here, we have the erythrocytes, we have here the platelets, okay? And then you're seeing here as far as the different types of, so you have basophils, eosinophils, neutrophils. The neutrophils you'll see, and we're gonna look at it in more detail, but they have multi-lobe nuclei, okay? You're seeing here the lymphocyte and the monocyte. The lymphocytes are smaller as far as agranular are concerned than the monocytes. The monocytes are the larger of the white blood cells. The plasma is the fluid portion of the blood, okay? And so primarily, predominantly water is its composition. Plasma proteins are present. Know that albumin, globulin, fibrinogen, these are other plasma proteins that are flowing within the blood, okay? They allow for other substances to grab on to and to attach to the plasma proteins and to enable them to pass and being transported through the blood. Plasma solutes, you would think in terms of ions, nutrients, waste products, gases, right? So we know the gases as far as oxygen and CO2, as far as waste products, enzymes, hormones, these are all solute substances passing through and dissolve within the plasma. When we use the term hematopoiesis, and you might have heard this, or hemopoiesis, we're looking at blood cell formation, and you know, as far as in studying of the skeletal system in ANP1, that this takes place in the red bone marrow. And know that all of the marrow within the body, predominantly there's yellow marrow, which is a storage area for adipose tissue, fat tissue, but we have red bone marrow that would be in the epiphyses of the bones and flat bones. This is where red bone is predominant, and know that children, infants have a higher level of red bone marrow in their body, in their skeleton, in comparison to adults. And also, I believe that you would remember that yellow bone marrow, if there's a need present within the body for more blood cells, that yellow marrow can become red marrow, okay? The stem cells are undifferentiated mesenchymal cells that can actually become different types of blood cells. Now, erythropoiesis. So this is then the production of red blood cells. Okay, so erythropoiesis involved in red blood cell synthesis taking place within, again, as all blood cells are produced within the bone marrow. Erythrocytes can last approximately 120 days. So, you know, it can last a pretty long time. But know that white blood cells, and in particular memory type white blood cells, can last for 10 years and greater, okay, because they allow for us to have, excuse me, a specific immune response to specific antigens that our body will encounter. And we'll get into more detail regarding that when we look at the lymphatic and immune system. Erythropoietin is a hormone, a protein that will then will stimulate red blood cell erythrocyte formation, production. We have stem cells that will become then these proerythroblasts, becoming the erythroblasts, becoming these reticulocytes. And know that this reticulocyte here, this is an immature red blood cell. A reticulocyte is an immature red blood cell. Okay. So the erythrocytes themselves, right? They're very unique in their structure, and as a result of their unique structure, it really does enable, as throughout the whole body, structure dictates function. Remember that? That's a very important concept to remember and to recall. That structure dictates function, and as a result of the erythrocytes' bioconcave disc shape, it allows for the best opportunity to transport oxygen throughout the body in the blood, okay, to the tissues of the body. It's anucleate, right? So erythrocytes do not have a nucleus, right? They're primarily they're sacs of hemoglobin, okay? Sacs of hemoglobin. So you're seeing here that the erythrocyte contains 1/3 hemoglobin, 2/3 fats, lipids, ATP, carbonic anhydrase enzyme, and this allows for then the transport of oxygen. So you see here as far as the heme and the globin portion of hemoglobin, allowing for transportation of oxygen and CO2. Know that CO2 does not transport in as high a percentage in the within the red blood cell as oxygen does. So CO2 will also transport in the plasma of the blood, okay? And know that iron is required for oxygen transport. So if you are deficient in iron, then this can be a problem. This can lead to an anemia, and we'll look at that in more detail when we look at my handout that I produced for you all. So hemoglobin, red pigment contained within the erythrocytes, okay? Containing, again, you saw there just in this, here as far as the heme molecule, the globin molecule, how they're binding to different gases, right? Know that the erythrocytes, right, like I said, if they have oxygen present and they're carrying them within, then it would be called oxyhemoglobin. Carrying CO2, carboxyhemoglobin, right? Hemolysis would be the actual destruction of blood cells and such. So let's look here and see as far as oxygen and CO2. So you'll see here that oxygen primarily attached to hemoglobin in the erythrocyte, and only about less, like 1.5% of the oxygen is transported in the plasma. Whereas what did I say before, that know that really only 23% is attached to hemoglobin present within the erythrocyte, and then 70% as bicarbonate in the plasma, and 7% as CO2 in the plasma. Let me go back for a moment. I need to just adjust this here just so that you're not getting this. Okay, I think that'll be better for you. It's easier for you to recall that and understand, right? So really only, so 98.5% oxygen attached to the hemoglobin present within the erythrocyte, and CO2, 23% attached to the hemoglobin. So the remaining, it's present within the plasma either as bicarbonate or as CO2 itself. Now here we have, like I said, we mentioned about the leukocytes, the white blood cells, and we said that there are granular and agranular leukocytes, white blood cells. So the granular, or primarily, like I said, as far as never let monkeys eat bananas, right? The N neutrophils, that's important to know that those are the predominant white blood cell present within the blood. They have a phagocytic ability, right? Phagocytosis, cell eating, quote unquote, cell eating. This ability to attack any type of bacteria that can be present, antigen antibody complexes that we'll talk about in more detail, but know that the antibodies are what your body is producing, all right? And in particular, it's being produced by different types of white blood cells, and we'll talk about that again in more detail. But it's specific types of B lymphocytes in particular. Okay, so there's T and B lymphocytes. We'll talk about that more detail when we get into the chapter regarding the lymphatic system and also the immune function of the body. Okay. This lysozyme is an enzyme that can be secreted, and this will also be involved in the destruction of whatever the neutrophil is attacking. Okay. Now they are very powerful, and so they do not last very long, because if they did last very long, as far as their lifespan, they could really work to create quite a problem for our immune system in our body, and really start then attacking our own. So like having an autoimmune type of a situation. So neutrophils, very short life span. Eosinophils, they are actually producing antihistamines. So in response to allergies, right? So we develop an allergy and we have an allergic response, we're going to produce histamines, which will increase the inflammatory response. So antihistamines will decrease the inflammatory response, and also eosinophils also are involved in the attack upon parasites. Okay. Basophils, again, we said that this is the leukocyte that is present in the least amount. Okay, the lowest numbers of leukocytes present would be basophils, and they produce heparin, histamine, serotonin. This will actually then really be involved in giving more, like contributing to the inflammatory response within the body, and as a result of allergic reactions, basophils. Monocytes and lymphocytes. So lymphocytes, I said to you that T lymphocytes and B lymphocytes, they're two different types. These are agranular, cellular response. T lymphocytes we'll talk about in more detail regarding the helper T cells, and even how AIDS, actually HIV virus, the HIV virus can attack the helper T cells, which really are the major factor involved in producing our specific immune response. So having issues with attacking the helper T cells, facilitating the immune response is a very bad thing. So this is why HIV can be very what is deadly if not treated. So that's the cellular response. The B lymphocytes are a type of B lymphocyte, are a type of lymphocyte that actually will mature within the bone marrow and be involved in producing antibodies. These antibodies will not directly destroy a cell per se, but involved in the whole process of marking out something that is a non-self cell. So it's something that's foreign to the body, and it'll mark it for destruction by a monocyte, a macrophage, a neutrophil. Okay. White blood cell movement. Okay. So the use of these pseudopods, and it's a pretty cool. You can go online. I'll look up some video that I can share with you, as far as some links to YouTube video regarding the showing of the different movement of these white blood cells moving from the blood to the area of damaged tissue and such. So diapedesis, this is when the cells thin, they elongate, and will move between or through the capillaries, the thin-walled capillaries, right? Then chemotaxis, it's really the movement toward an area of damaged cells or foreign cells that is releasing chemicals from the damaged area in order to draw the white blood cells to the area to help in the healing process. And then amoeboid motion or movement is as a result of the pseudopods of the white blood cells that are allowing for this amoeboid type of movement to the area of damage and inflammation. Yeah, let me just take a look at that for a moment there. So I want to show you. Let me just minimize this. Let's go to the web, and I can at least show you an image. Here we go. Yeah, here we go. Okay, so you're just seeing here, as far as we're having yeah, so you're seeing here as far as movement of white blood cells through the tissue and to the area of damage. I'm looking for another image that I've shown in the past that I really like. Here we go. Let's see here. Yeah, this is a good one. This is good in that you're seeing how the white blood cells present within the blood. Here's the blood vessel, okay? And so we're having movement through the tissue, through the blood vessel, and these chemotactic factors are these chemicals that are being released by the damaged area, drawing the white blood cells to the area of damage, of inflammation, of infection, okay? So let's look as far as, so the inflammatory process. So this is important as far as you should know, and after this slide, I'm gonna take a moment and just ask for questions. But you'll see here as far as occurs when living tissue is damaged in any way. So is inflammation a bad thing per se? No, it's not, really. So short-term inflammation is a good thing because this is your body's natural response to some type of injury, infection, whatever it may be. It's going to allow for the healing process to occur. So redness, right? Heat. Heat as a result of that redness, you're going to feel. So it looks inflamed by seeing the red skin. It'll be hot to the touch. You'll see swelling that can take place as a result of increased fluid to that area, and then pain and discomfort as a result of the chemicals that are present from the inflammatory response, and also as a result of the swelling of tissues can cause pain and discomfort. So you should know these different signs. And then also another sign of inflammation would be the act of really decreasing the function of an area that's been damaged by, that has been injured, damaged, infected, that can lead to inflammation. Okay. So let's do this. Let's stop for a moment here. Let's show everyone. And so, folks, you tell me, do you have any questions or comments or anything that you'd like to add to the discussion so far regarding the blood and looking at the red blood cells and the white blood cells and inflammation? Have any personal experience with inflammation? I can share something with you in a moment,
I
but
have
I'll
a
wait
fun
for
one
you.
for all of you.
Yeah, let's hear Skylar. Go for it.
All right, so Friday, this past Friday, I had to take myself to the hospital because I rewarded myself with my for my hip surgery by getting an new ear piercing in my cartilage called it was a rook piercing, and I've never really had a major issue with piercings before, and it was healing for 3 weeks fine, and then suddenly my ear started swelling up over the course of 3 days, and I looked like I had like a wrestler's cauliflower ear. And then I went to my doctor, they gave me amoxicillin, and by the next day after 2 doses, it still wasn't going down. It was spreading behind my ear to the lymph
Goes to the
nodes.
mastoid.
Yeah.
It can go to the
Yep.
mastoid process of your skull, and this could then God forbid you don't want it to travel to your brain. My gosh, right?
Well, that was
So
the
very
fear,
scary.
right?
Mm-hmm.
So
wow.
my little sister says hi. So I ended up, I'm helping her with homework. I ended up taking myself to the hospital, and they gave me they drained it, which is painful, and they gave me an IV push of antibiotics to help clear it up.
Right.
But yeah, no, it was terrifying.
Oh,
It was
that's terrible.
Yeah, it was not fun.
And plus,
Just
it looks
take
really
yourself.
weird too. I mean, in addition to, what else, the process
Oh yeah,
that's
I was
going
like
on.
sticking out like this, and
Yeah,
it was just,
yeah.
yeah, no, not fun.
So to piggyback on that, right? I would tell anybody that anything to do with, the face, the ears, please, if you see some sign of infection, don't just let it go and oh, it'll be fine. Please, because that can travel to the brain, and then that could be a major, major life-threatening issue. All right. Thank you, Skylar, for that input. So Megan, so the movements of the white blood cells all happen together in specific times or different? Yeah, well, really, Megan, what's going on is that in regard to damage, in regard to infection, right, as far as like bacteria and such, then that's when the white blood cells will move to the area. All right, you got your wisdom teeth out, and now you're dealing with swelling and inflammation of that. Oh, I feel for you. Had that done too, and that's just that's no fun. It's terrible. Sorry for you. I hope it heals up quick for you. But yeah, that's some tough stuff for sure. Wow. Yeah, plantar fasciitis. Okay, so there you go. So that's an area where you have inflammation taking place of the soft tissue and connective tissue of the sole of your feet, and really plantar fasciitis. It can lead to a very tightening of the soft tissue on the underside of your foot, and what can happen is that it can start pulling on the calcaneus and lead to a heel spur. And so, trying to treat that and deal with that is important, especially for those people who are involved in standing for long periods of time during the day, during their work and such. This can be something that needs to be addressed. And so good supportive footwear are very important, and stretching, icing the soles of your feet, very important also. You're welcome. Yeah, osteoarthritis, right? Yeah, that's one on the the hit parade there. As it's gotten colder outside, if any of you have any type of injuries, I know myself included, I've felt it more as it's been getting cold at night and in the morning. It doesn't make those joints feel very happy. So inflammation, inflammation of the joints, any type of arthritis is not a fun thing to deal with for sure. All right, folks, so let's move on. I'm gonna hide everyone and we'll share more with the screen and go on into our PowerPoint. Okay. So you should know the signs and symptoms of inflammation. Like I said, in addition to those four, you should know also the reduction in function of an area that is inflamed. So the platelets, aka the thrombocytes, these are important. These are little cellular fragments coming off of a megakaryocyte. So a large cell, these fragments of the cell of the megakaryocytes are these platelets, and they're cellular fragments with a nucleus, which is quite interesting, right? Because you would think a fragment of a cell wouldn't have a nucleus, but it does, and they're involved in really making sure that in the maintenance of the ability to clot. Uh, in addition to clotting factors. Platelets play an important role in that. And you'll see here, as far as the clotting mechanism is concerned, I'm not asking you to memorize this, but I want you to just see what takes place as a result, and how there's quite a bit of detail going on regarding leading to from the ruptured blood vessel, right, which attracts those platelets. And remember, didn't we say this as far as in AMP1, we talked about positive feedback, and we said that the clotting mechanism really is an example of a healthy example of positive feedback in the human body. The birthing of a baby, of a child, as well as the clotting mechanism, both positive feedback, healthy positive feedback, because the ruptured blood vessel will attract platelets, thrombocytes, right? And it'll keep on attracting more and more platelets to the area until the wound is until the damage is closed up, right? And you'll see here that we have these certain proteins present. Okay, these proteins are all present, and they're going to lead to the intertwining of these different fibers with the platelets. And these platelets and fibers will all become part of that clot that helps to heal and close up the damaged tissue of the blood vessel. Okay? So the clot, and I just said that, right? So fibrin forms these long threads that act like a net, and the platelets get enmeshed. So we're pulling more and more platelets to drawing them more to the area of damage until they interweave with this fibrin, and they'll help to block and cover and close up the damaged blood vessel. So you're just seeing here as far as terms that we use, as far as syneresis, clot retraction, fibrinolysis, the actual dissolution of the blood clot, and these are all part of the actual healing process of the clot, and the initially having that clot present, and then as the tissue starts to heal itself, then we do not need the clot anymore longer because the tissue is being healed. These terms here can get very confusing, to be honest. Okay, so thrombosis, thrombus, and embolus. So thrombosis, clotting. The thrombus itself is a clot. So a circulating clot would be an embolus, right? An embolism is when we have this clot that was been moved to a specific location, then it ends up blocking the total blockage of blood flow, and this can lead to death of tissue distal to the clot. Okay? So in the case of an infarction, right, tissues are killed as a result of loss of blood supply. So there can be a clot that forms within one of the blood vessels in the heart, and this can then stop the passage of blood distal to the clot, and this can lead to death, tissue death as a result. So here you're seeing, as far as the clotting mechanism is concerned, from the cut to the actual production of the fibrin and the drawing of the platelets to the area in order to close up the area. In addition to, and see that also, and this, I didn't mention this, but know that in addition to, so that netting of that fibrin, of those proteins present there with the platelets, we also have red blood cells are also intertwined within that mesh, contributing to the blocking of the flow of blood out of that damaged area of the blood vessel. So blood typing, right? Blood typing is quite interesting. So there are different types that we can use as far as different groups and such. Primarily what we're doing is we're using the A, B, and O, right? And we're also using positive or negative. So we'll discuss that in a moment here, as far as we're talking about antigens present on the erythrocyte's plasma membrane, and also factor present. Whether we have the factor present, it would be positive or negative. We'll talk about that as far as RH is concerned. Okay? The term agglutination, this is the term that's used for the clumping of erythrocytes, of red blood cells together. Okay? This occurs as a result of, so if someone has type A blood and they receive type B blood, that wouldn't be a good thing. And this can cause a reaction to occur. This can lead to death if it's not addressed and handled. Okay? Because know that this agglutination will clump. It will cause the blood vessel, I'm sorry, saying that again. The blood cells to group together can this lead to a blockage of blood vessels, smaller blood vessels, absolutely. Can this also lead to a lack of erythrocytes carrying oxygen to the tissues? And yes, that can occur. So the A, B, and O. So in your third lab of the semester, the third full lab of this semester, we will be doing a lab that will be practicing doing blood typing. And I think it's an interesting lab. We're using synthetic blood. We're not using real blood, but you'll see that we'll be able to determine whether the samples that we're working with are type A, type B, type AB, or type O, and whether there's the RH factor present or not. Okay, so quite interesting. You need to know the universal donor and the universal recipient, please. Okay, so the AB and universal donor, type O, RH negative. And I said to you before that on the plasma membrane of the erythrocyte, the red blood cell will have either these type A antigens, type B antigens for type B blood, type A and B antigens on type AB blood, Or type O blood has no A or B antigens present. And so let's see if we can, okay, no, all right. So we're going to take a look at, I'm going to show you online here. And I'll show you just, yeah, here we go. This is very simplistic, folks. No, images, here we go. And we'll look at this one right here. Okay, well, let's look at one bigger. There we go. All right, so you'll see here that, look up on the top here, this image. And so we're looking at type A, type B, AB, and type O. So on type O blood, there are no A or B antigens present, okay? But type O blood does have A and B antibodies present, okay? But there's no antibody antigens, there's no type A or type B antigens present on type O blood. And I'll review this also when I get into the class as far as for our lab is concerned. Oh, I see another image that I want to show. So type A blood has type A antigens on the plasma membrane of the erythrocyte. Type B blood has B antigens. You see how they're different than the type A, present on the plasma membrane of the erythrocyte. Type AB would make sense. It's going to have type A antigens as well as type B antigens present. And you see that on this erythrocyte on the plasma membrane. Now know that if we have A and B antigens here, we cannot have A or B antibodies present in the plasma, or we would have an autoimmune response. Our body would have the antibodies attacking our own erythrocytes. Can't have that, right? Type B blood has B antigens, so it would make sense that our immune response would produce type A antibodies. So if we have type A blood within this type B blood, what's going to happen? We will have these A antibodies attacking and holding on to and allowing for a clumping to take place of the type A blood within this type B blood that the person has. So that would be a transfusion response, which would be very bad. Or we could say the other thing, I have type A blood and I have these B antibodies present in my blood, and I am given type B blood when I have type A blood. It's bad, right? So what's going to happen is that these B antibodies will latch onto the type B blood that I've been given, and it will allow for the type B blood to start agglutinating. They're going to all clump together, and that's a bad thing. That's a response that's going to occur that can lead to that can eventually lead to death if not taken care of. Let's look at another image just to see. I just kind of like how this looks a little bit better also as far as the blood typing and just giving you a visual representation. So look at here, type O blood has no A or B antigens present, antigens. But what does type A have? Type A has these green pointy antigens, just for the sake of, Type B has these blue antigens present, right? And type AB has both antigens present on the erythrocyte plasma membrane, okay? So like I said, we'll go over this in more detail in the lab. Well, not in more detail, but just in a review, and also you'll do the lab, and I think you'll find the lab quite interesting. Okay. Now let's look at, and so again, just as a review for this, let's go here. So then again, type A blood will have the A antigens and the B antibodies. Type B blood will have the B antigens and the A antibodies. Type AB will have the A and B antigens, no antibodies for them. Because if it did, your own antibodies would start attacking your red blood cells because they contain A and B antigens. And then type O, there's no A or B antigens present, but there are A and B antibodies present in the blood. All right, as far as the RH group is concerned. So I'm going to stop for a moment here, and I want to just ask a question. And then I'll answer these questions. Let's see here. I'm sorry to hear that, Abigail. That's terrible. And also, and Megan, how's a, yeah, so Megan, so dealing with the fact that it's the Rh negative, because know that we can have a problem, and let me show you this. Let me show you this. Let me hide everyone for a moment, and I'm going to share with you, and I'm going to show you regarding a problem that can occur with a Rh negative mom and Rh positive baby. Okay, this is a good image here. Okay, close that up. All right, so take a look at this here for a moment. You'll see. So an Rh negative woman and an Rh positive man conceive a child. The Rh negative woman will have Rh and can have a possibility of having an Rh positive fetus because dad is positive. So that's a possibility genetically. Okay. Now, the cells from the Rh positive fetus can enter the woman's bloodstream, and the woman can become sensitized to these Rh positive red blood cells because she doesn't have them, right? So her body's going to mount an immune response, and what will happen is that it's not really the first pregnancy that's going to be the issue. It's going to be any kind of subsequent pregnancies. If the Rh mom has an Rh positive fetus, then the second pregnancy and beyond, she can develop an immune response to the fetus. So the next Rh positive pregnancy, maternal antibodies can attack the fetal red blood cells, and this can lead to the death of the baby. So we have ROGAM and different ways of working at helping the mom not to develop an immune response to her babies that are Rh positive if she so has any. So yeah, I'll post an image like this on the website for you all in documents and resources. Okay. So let's. Oh, I'm sorry. I'm going to go back to answering. See if we have any questions. Okay. All right. So does anybody else have any questions or comments so far? Anybody have any questions or comments regarding blood typing and such? So I'll move on, but I wanted to show you that that's erythroblastosis fetalis. That's what goes on as far as the reaction of mom to, if mom is Rh negative, to an Rh positive child within. Now, let me ask you, does anybody have any experience with this as far as have you heard of anybody that suffered with this kind of a situation with the Rh negative and Rh positive situation for babies? What'll happen is that when you go through prenatal testing and such, they're gonna know what blood type you are, and then they're gonna be able to know that if you're Rh negative, they're gonna be looking to see if you do have an Rh positive, if there's that possibility, and they'll do treatment preemptively in order to help you not have an immune response to your baby. Interesting with the Rh positive. We had to check into this with finding a donor and seeing. Yeah, interesting. Yeah. So yeah, very very important that these are knowing the A, B, B, O typing as well as positive and negative, very important. Okay, very important. All right, I'm going to hide everyone and share my screen. All right, so the Rh antigens. So there are different types of Rh antigens. So the D is the most important. So the anti-Rh antibodies develop after exposure. So really, it's really during the birthing process that really mom will be exposed to the mixing of the blood, and so having issues as far as issues where the Rh negative mom would develop Rh positive, or would develop Rh positive antibodies against the child. So the erythroblastosis fetalis, so Rh negative mother carrying a Rh positive baby. ROGAM is being used in order to protect the fetus, and again, testing is done very early on to figure this out, so there's not an issue. Okay, and so what I'm going to do right now, folks, is There we go. All right. We're going to take a 5-minute break. Okay. So we're going to take a 5-minute break. And then we're going to come back and I would like to review this Word document here. Okay. So I will post this Word document for you all, and then we'll come back and we will look at it. So we'll take about a 5 to maybe 7 minutes actually. So bathroom breaks, that kind of a thing, come back, and then we'll finish up by looking and reviewing this Word document, okay? I want to post this for you all. So that's what I'll do first off. All right, so see you in about 7 minutes, folks. Okay, folks, so I've posted the blood pathologies in documents and resources in Unit 2. Okay, so you can download that off of the website there, blood pathologies, and I'll see you in about 5 minutes. Thank you. Okay, folks, so we're looking back at our, I don't know if you had the opportunity yet to get the Word document as far as blood pathologies are concerned. You can just observe and look along with me, and then later on download that off of the site very easily. It's only a 3-page document. So you'll see here that as far as we're going to be looking at erythrocyte, red blood cell, white blood cell, and thrombocyte platelet disorders. Okay, so when you're thinking of these disorders, think that you're going to either have too much of something or too little of something, right? Whether it's the numbers of the cells, higher numbers of the cells or lower numbers of the cells, or the actual ability for the cells to do the job that they're meant to do. Okay, so in case of anemia is concerned, right, there's 3 different groups. There's either as a result of blood loss, as a result of low red blood cells being produced, or high numbers of red blood cells being destroyed. Okay, so it leads to, right, low oxygen carrying capacity. That's the issue. So we're not getting oxygen to the tissues. That's a problem. That's very bad. The tissues need oxygen. Cells will die as a result of lack of oxygen to the oxygenation, and also a removal of CO2 and different waste from the tissues, from the cells and tissues. So you'll see here, as far as the blood type, blood cell, blood loss type of anemia that we can have, hemorrhagic anemia as a result of some type of trauma injury, right? Major blood loss, right? Treated with blood replacement, because if you've lost blood, you need blood in order to fix the problem, right? And stop the actual wound from allowing the blood from leaving the body. Or chronic, right? So chronic condition is a condition where it's not just an acute short-term condition, but it's a condition that's over extended periods of time. So how about a slight but persistent blood loss in the case of hemorrhoids or an ulcer within the digestive tract, right? Primary problem should be treated. So the hemorrhoids or the peptic ulcer that's present in the stomach or the duodenum, right? That's taken care of, and so that we can correct that anemia. How about low red blood cell production, right? So if we're not producing enough red blood cells, there's not going to be enough red blood cells circulating in the body, carrying oxygen to the tissues, removal of CO2 from the tissues. That's a problem. But in particular, it's really the delivery of the oxygen. That's the issue, folks. And so iron needs to be present in order for the hemoglobin to be able to produce and do its thing. And as a result, its function, you'll see iron deficiency anemia. This can be, iron supplements are pretty hard to handle by the body. And so even iron infusions can be the way where we actually have an infusion, intravenously into the body in the hospital setting or in some type of outpatient setting. Very important, can be very helpful, okay? As far as pernicious anemia, this is a situation that occurs, it's an autoimmune process that occurs, destruction of the stomach mucosa. What will happen then is, and we'll see this as far as in the digestive system, there's a lack of intrinsic factor needed to absorb B12, can be a deficiency. So what will happen then is that red blood cells can't divide. We end up having these cells that are non-functioning, right? And so as a result, we can have issues with transport of oxygen to the tissue and red blood cell production. Aplastic anemia as a result of, folks, could be as a result of exposure to radiation, to some type of, how about this? It can also be as a result of chemotherapy, okay? But exposure to other chemicals and such, and as a result of some type of treatment. And viruses can also be a cause of an etiology of aplastic anemia, but many times the cause not known, so the etiology unknown. Affecting all the cell lines, so not just the red blood cells, but aplastic anemia can affect all the different formed elements, right? Production, okay? Also, transfusions and stem cell transplantation can occur in order to help with aplastic anemia. Yeah, how about as far as case where hemolytic anemia? So when you think of hemolysis, you think of actual destruction of the erythrocyte. And so can this be caused as a result of abnormal hemoglobin, right? Can be as a result of a transfusion reaction. This can be as a result, or infections, right? Some type of infection that can cause the red blood cells to be destroyed, which can then lead to the fact that you're not then transporting oxygen to the tissues. How about Cooley's anemia, aka thalassemia? This is Mediterranean ancestry, so I have a couple of people in my family that suffer with this, and it's as a result of our Italian heritage and such, and genetically being passed on to some family members. Not my close personal family, but an extended family. The red blood cells are thin, delicate, deficient in hemoglobin. Again, so this is problems with, the early destruction of the erythrocytes. Sickle cell anemia, you've heard of, I'm sure, and know that these crescent-shaped cells have issues. So red blood cells, crescent-shaped, when they unload the oxygen or the blood is too low in oxygen. So yeah, even in the presence of low levels of oxygen being transported in the blood, the cells can develop this crescent shape. They rupture easily. They can actually, because of this shape, can also block small vessels, and this can be very painful disorder. Yeah, really sad disorder for sure, indeed. Polycythemia vera, right? So this is a bone marrow cancer, so can result in an excess of red blood cells, right? So we know that predominantly the blood is containing red blood cells, but know that if you have too high a level of red blood cells, it can lead to increased viscosity of the blood, and this could like a thickening of the blood itself, and this can cause issues. This can lead to a heart attack. The thickening of the blood, it's having issues being transported throughout the body. So in the case of, say, like Lance Armstrong, okay, and other professional bicyclists, right, that are involved in doing these tremendous feats of like, to think of how many miles that they ride on these bikes and the speed at which they ride these bikes, right? In order to get an edge, that they would actually do blood doping, where they would actually have blood in the off times, have blood be removed from their, so they sort of go, they donate blood to themselves. So they have blood removed, and then they actually then will take transfusions of their own blood, which will increase the amount of erythrocytes flowing through their blood, which could do what? This is prior to an event, which will increase their ability to process oxygen and transport oxygen to the tissues, in particular to the musculature of their body. And this can help, but it's a very dangerous thing to do. And they were doing it in very sanitary places like hotel rooms. They were taking these blood transfusions prior to their events and such, and pretty crazy stuff. As far as leukocyte disorders, so we have leukopenia. So when we see the term penia, we're talking about abnormally low white blood cell count. Okay, this can be a result of different drugs that have been taken over the counter or not, or illegal. Leukemias, we're talking about increased levels of white blood cells flowing through the body. All fatal if untreated, know that. So there are leukemias that are very slow acting and slow moving, but still, even though that they are very slow moving and slow acting, it can still lead to the death of the patient if untreated. Let's see here. Yeah, so the myeloid leukemia involves the myeloblasts descendants. So it involves specific types of white blood cells. The lymphocytic leukemia involves specifically the lymphocytes. So the B and T lymphocytes can be affected. So there's different types, and know that, like I said here, acute and chronic. So really these acute leukemias derived from the stem cells, and again, affect primarily children. We had a young man when I was working with kids as far as in a youth group when I was a young man with my wife. Actually, not my wife at the time, but we worked with these kids, and one young man suffered from an acute leukemia, and we saw for many years him going through different treatments and such. And it's really this is back in the late 70s, early 80s, and really tough stuff that children go through as a result of these different disorders. It's horrible. It truly is. Platelet disorders. So thrombocytopenia. I actually have a close friend who suffers with this, and it's unknown etiology. Don't know why it happens, but it's a platelet deficiency. And this is a problem because if you damage any part of your body and issues where there's bleeding and such, if you're not having enough thrombocytes, enough platelets, this can affect your blood clot formation. Petechiae, really, usually these appear due to spontaneous widespread hemorrhage. Let me show you what petechiae looks like. Okay. So when I think of petechiae, this is kind of what we're thinking of, these little hemorrhages on the skin. Okay. They can be pretty brutal, actually. There's, Okay. So infectious mononucleosis, know that, so you see here it's viral disease, highly contagious, Epstein-Barr virus, and know that pretty much 90 some odd percent of the population in America have the Epstein-Barr virus present within. It's just that not everybody gets sick as a result of the Epstein-Barr virus, and not everybody has that does get sick gets the total devastation of their immune system by being tired, achy, chronic sore throat, low fever. This can affect a patient for a couple of weeks to even a couple of months. It can be very, very rough to experience. Let me just ask this of you all: has let me this. There we go. And let me answer some questions here. But before I answer the questions, I'll come back in just one moment. I want to know, as far as has anybody ever known someone to have infectious mononucleosis, or experienced it themselves, and how they felt as a result? No? Nobody? Okay. All right. So the doctor that I work for has a daughter with sickle cell. Yeah, wow, Sam, that's tough stuff, boy. And again, too, I've heard that can be very painful and rough stuff. Megan, my classmates, they're trying to get years ago when he's in sick. Yeah, so you know this, Will, that people can get mono, and it's not just the teenage kissing disease, so to speak. Okay. All right, so know that there, yeah, for sure. All right, so let me hide everyone. We'll finish up our sharing of the information here. So I just gave you, as far as, again, a reiteration regarding and a review of thrombus, embolism. So you can review that and look at that. Anticoagulants, okay, so if we're looking at clotting and such, so aspirin, heparin, warfarin, aka Coumadin, these are all anticoagulants that can help prevent blood clotting. And folks, blood clot travels to the brain, travels to the heart, travels to the lungs. This can be deadly, right? And hemophilia. Hemophilia, I mentioned earlier today when I talked about that, clotting factors need to be present. And know that with hemophilia, whether we have hemophilia A or B, different clotting factors can be present or actually absent. Sorry, correct that myself there. Different clotting factors can be absent and this can affect clot formation, and this can really affect what goes on as far as a patient. So young people that have and older people that have hemophilia really have to be very careful. If they're involved in any type of physical activity, they can have bleeds. They can have bleeds and not even know that they have bleeds until a day or so later and have major bruising. Folks with bleeds that can go for extended periods of time can be deadly. So hemophilia can be deadly, although at this point in time in the treatment that's done, there's no curing, but we can sufficiently treat patients with hemophilia, and they can lead relatively active lives.